Hi, and welcome to NANNcast. I'm Jill, your host. Respiratory therapists are the unsung heroes of the medical world and often are underappreciated or even not well known, but their efforts do not go unnoticed by NICU nurses. Nearly all newborns run the risk of respiratory difficulties at birth, according to the March of Dimes. Those born prematurely often have breathing problems due to underdeveloped lungs, but full-term babies can also develop respiratory issues from a difficult labor and delivery, birth defects, or infection. Respiratory care in the NICU, in collaboration with other medical disciplines, can reduce length of hospital stay, as well as lower risk of long-term disability. Neurodevelopmental outcomes for our babies is so important, and it really is our focus when at the bedside. Respiratory therapists play a crucial role in this as well. To discuss this collaboration, as well as challenges in respiratory care, please welcome respiratory therapist Kim Glebleh. Kim has been a respiratory therapist for over 13 years in Helen DeVos Children's Hospital Gerber Foundation NICU in Grand Rapids, Michigan. There, not only does she work in the Level 4 NICU, she also attends deliveries and neonatal transports. Let's get right into it. Hi, Kim. Thank you so much for joining us today. I am very excited to have a respiratory therapist on NANNcast. I think you guys are tremendous in what you do. But for those that aren't fortunate enough to have a respiratory therapist in their NICU 24/7, can you give us an idea of what a typical day is for you as a respiratory therapist in your NICU?
Yep. Thanks a lot for having me, Jill. My typical day in the NICU probably involves getting to work and getting report, as we all do in the morning. We all get different assignments. There's usually, on a typical day, there's probably about 4 respiratory therapists that work in the neonatal ICU. We're lucky enough to have a transport person who will be in-house with us unless they go pick up a baby at an outlying hospital. So we all get different assignments that entail either different ends of the unit. We also have a small baby unit within our neonatal ICU. Some of us get assigned deliveries. And there are a couple of satellite labs as well in which we run our CBGs and ABGs. So those also go to an assignment. So we all have different assignments and we get report and pretty much hit the ground running on a typical morning.
So the small babies unit that you have in your NICU, are those respiratory therapists just working with a small population of babies, less than what is yours, 27 weeks? And how are they utilized in the small baby unit?
So we are one of the few neonatal centers in the country that has a designated space within our NICU for babies that are born less than 27 weeks. And typically they weigh less than 2 pounds. So our small baby unit is designed specifically to meet the medically complex needs of these babies. And the staff that work in this area have received extensive training in the complex care of these very fragile babies. So there are a select number of us respiratory therapists that have specific training. And we tend to get into that small baby unit a little more frequently. And then there are those of us who really enjoy it and like to get in there more often as well.
Yeah, I think that's the trend now is, the centers that have a lot of premature baby deliveries, they are creating these small baby units where, all the care is focused and everybody has that extensive training because we all know how fragile these babies are, right? And, the littlest things that we do when any kind of overstimulation we give them, the detrimental effects, neurodevelopmentally that can occur. Right. I know we, on our unit, we've designed a whole IVH prevention bundle, and we couldn't do what we do without the help of our respiratory therapists. They're actively involved in all aspects of our IVH prevention bundle. And, I can't commend respiratory enough how they really, took on that role to help us with that. And I think a lot of times we always think of the bedside nurse, always at the bedside and always doing care for these babies, but there's so many hands that touch those little guys, and especially respiratory. So how do you, in the small baby unit, how do you collaborate with the nurses to ensure that neurodevelopmental care and to ensure that, they're not getting overly stimulated and create that neuroprotective environment?
Well, typically back in the day, there used to be care times. They'd be an 8 and a 2 or a 9 and a 3. And I think what we're getting more toward, which actually we started with our small baby unit, is cue-based care. And our small babies, we pretty much just watch the cues. And so we go in when they are awake, and the nurses will contact the respiratory therapist. And that's when we go in and we do our containment. Each of us has certain things that maybe we want to do with this little patient, little tasky things that need to get done, but they don't always get done all in one visit. So we watch their cues. We're careful not to overdo or overstimulate. We use containment. Another thing in our small baby unit specifically is that it's very dark, or I shouldn't say dark, it's actually just dim and quiet. So it's funny because we call the small baby unit, the rooms, we kind of jokingly call them the wombs. But it is interesting to see how a lot of what started out as just our small baby unit care with a cue-based and has somewhat carried over into the rest of the neonatal unit, even with the bigger babies now, with painful procedures, heel pokes to get gases, CPAP care. We've started integrating two-person care with that with bigger babies as well.
That's great. I know. I think a lot of times we get focused on our tasks, like you said, like finish the tasks at hand. And we had that, everybody gets done every 3 hours with feedings and I must suction. And even though you listen and there's, you don't hear anything, but I got to suction because that's part of my care. So it's a hard shift and a culture change, but I think nurses are finally starting to get it. We don't need to suction every single time we do care.
Exactly. And we're even using BBGs probably most of the time now. We're not deep suctioning anymore. It's just BBG if they need it.
Exactly. I know. But it's trying to get those people that are so used to doing it one way to make the change.
Yeah.
And I love how your small baby management transferred over to the big kids and the term kids and the other kids that are there. That's great.
It is neat.
With the small baby units, I know we try to encourage kangaroo care, skin to skin, but I know a lot of times nurses are fearful of getting the baby out of their isolate, and when they're on, the oscillator, the jet, conventional ventilator, even CPAP. And I think that fear stops nurses from offering that, or, because it's a lot of work to get a baby out for the parents to hold, but, the outcome is so rewarding. But as a respiratory therapist, what are your tips, or how do you help the nurse do that and make that successful transfer so we can have that much needed skin to skin time and bonding with the parents?
Well, first, I love skin to skin. I always make sure that when I touch base with my nurse first thing in the shift, I always say, especially if a baby's on a jet or an oscillator, I will say, hey, when you talk to the parents today, find out if they're coming in, what time they're coming in, so that we can have everything done with this baby, even with the circuit on the proper side, so that when they get here, they can hold for as long as they need to hold. Some parents are on kind of a time crunch. They might have children at home. But yeah, I love it. I always let the parents know how important this skin to skin is, that they are the only ones who can provide this special therapy for their baby. And that's exactly what it is. It's a therapy. It reaps so many benefits for both, and I say mom and dad both, because we have dads hold a lot, probably not as often as moms. I think sometimes they're a little more nervous, but there's just so many neurological benefits to the baby and the mom if she's breastfeeding, for milk production. So we really highly encourage it. I let the nurse know that if we collaborate and she can kind of give me a heads up, I try to make myself available, and I come in with a smile because sometimes, we have to get up from our lunch break because they're there but I just walk in with a smile, and I try to remember that what they're going through with having a baby in the NICU is it's just so different from like a parent who can bring their baby home and hold them all day long. So we want to make it not seem like a chore, and it's not, but we don't want them to feel that way because sometimes I sense from parents that they don't want to put us out. And if their baby's on a jet or an oscillator, it does take a team of about 4 to 5 people. It takes a couple of respiratory therapists and it takes at least 2 or 3 nurses. But we do it over and over again, and we've got it pretty down pat. So yeah, it's a big thing. We do it in the SBU all the time. And of course, out in the regular unit, the babies are, a little larger, conventional vents, more so. And most are CPAP and NIPPV. And our nurses do it on their own with CPAP and NIPPV.
I think it's just, like you said, parents do feel like, oh my God, they see us doing it. They see what goes into it. And I do think there's a little bit of hesitation to ask, to put us out. But once they do it, they fall in love with it. And it's, and we see what the effects are of it. And, if, like you said, just get it scheduled. Like, I love the word collaboration with the nurses. Like, you figure out what time the parents are coming, so you guys can schedule a date, a kangaroo care date. And then you can be there for the parents when they're there. All too often we control time for these poor babies and when a parent can do this and when a parent can't do that. And I love that you guys are collaborating together and including those parents and finding a time that works best.
And just kind of put their needs on the front burner. I mean, as you know, in a unit, anything can happen. And there are times I have parents that are waiting for me, but for the most part, I try to do everything I can to put them on the front burner. And I do let them know. Another thing, too, we try to tell them is when they come in, we do ask that they minimally hold for 1 hour. And they can hold as long as they want. And the reason for the 1 hour is because of the transition of getting the baby out of the isolette onto the parent. And they really start reaping the benefits of skin to skin after that, after like a half hour or so. But we've had parents, I had one dad who held literally from like 4 o'clock in the afternoon until 7 a.m. the next morning because he was trying to like break the record. But most parents hold for a few hours.
So how do you manage the skin to skin with a baby on an oscillator with that heavy tubing? So what are some tricks and tips that you have for respiratory standpoint as far as managing the tubing and securing everything to make sure that there's no extubation or anything like that?
Okay, well, when we have a baby on an oscillator, it takes 2 respiratory therapists. One will hold the ET tube and the circuit. The other one actually turns the oscillator as we're moving the baby. So then you have a nurse that has the baby, usually a second nurse that may have some of the lines, and then a third nurse is kind of just kind of a troubleshooter, maybe silencing the alarms, if we have any cords that snag on something along the way. And also we have a special chair that we use with our oscillator, and it has, the feet go up and the head goes back and the chair actually goes up and down. And we have a remote control for it. So the parents in the chair, and and of course the circuit, you want to make sure you get we all know how they get a lot of condensation. So make sure there's no water in the circuits, baby doesn't get a drink. And it's just, the respiratory therapist is typically the one who everybody gets ready. And then we're the ones that are usually, okay, is everybody ready? Okay, 1, 2, 3, go. Because we have the ET tube. So we're kind of the boss. And I do get a little bit bossy. But I think the parent also, when they watch all of the collaboration and they see that everybody has a role, and I think that puts them at ease. And it usually takes a couple times of them holding on the oscillator, and then they start to feel very comfortable with it. We have parents that come in every day and hold when their baby's on an oscillator or a jet. So, but it actually took training. Everybody went through training where they actually did a skin-to-skin simulation with a doll. And the parents, or we actually had employees get in the chair and pretend that they were mom or dad. So it felt, we got to feel what it would be like when you're the parent, and how weird that feels when everybody's kind of in your face,
Yeah, and
because
gathered around you.
I'm securing this. Yeah, it's a big deal. It's scary. And I usually will use a combination of like posies, and we have clips. So I kind of have my little tricks and tips for how I do it. And I pretty much have it down pat at like the angle of the chair. And the more you do it, the better you get at it. And there are other respiratory therapists that are great at it too. And they do it a little differently than me as far as securing the circuit.
It always
So,
amazes me to watch respiratory manipulate the arms and everything and how they can secure tubing in 2
I
seconds where I'm
know.
struggling trying to get it to look right. And they're like, oh, this is how you do
Yeah,
it. And you're, oh, you make it look so
yeah. It's
easy.
just like we have with everything, and you guys are good at other things that we can't do. So it's what you get used to.
That's why, like I said, respiratory is my favorite people on the unit. We rely on you
Oh,
guys so much. And I think that collaborations are really important with the nurses, but I also see a lot of collaboration too with respiratory and the healthcare team too, the
hmm
medical team. And, you know, you guys are a great wealth of knowledge. And I love when I see the doctors and the NPs asking respiratory, hey, like this is the gas, like what would you do? And it's such
hmm
a good multidisciplinary effort, to take care of these
Yeah,
babies. So we're
yeah. I mean,
lucky.
we like to feel needed too.
Well, you're the expert, I mean, at all of that. And, I don't even think some of the residents even really understand the true workings of an oscillator or a jet. So it's really important that everybody talks. Respiratory, I mean, most units respiratory is involved in rounds, patient rounding, to get their input, as well.
Yeah, I think that collaboration with other practices within our unit is very crucial. I think that all of us bring our own unique knowledge and insight to like the patient's experience. Um, I think coordinating care with the bedside RN as far as respiratory for me in the NICU is probably like my number one like in unit relationship. But then communicating with like the neonatologist, the NNPs, physical therapist. I love doing care with a physical therapist. A lot of times when I do CPAP care, they'll come by and say, hey, do you mind if I contain? Will you do CPAP care? I want to see how this baby responds. Maybe they want to see if they're ready to move them out of the small baby unit into like the big baby area. And then we do light transitioning. Then they go from 2-person care to 1-person care just for regular care stuff like diaper changes and whatnot. So the physical therapist, I learned so much from our physical therapist. I love them. They teach me how to tuck babies in the appropriate way. And I love doing that. When I'm all done with my care and the nurse will be like, oh, you can just leave them there. I'll get them all tucked in. And I'm like, no, I can do this because Jason taught me how. So yeah, I mean, I love working with everybody. Like I said, I think collaborating across specialties can really benefit the babies. It can benefit their families. It's easier said than done, and we are a work in progress still in our unit. But it's at least we're aware of it and we're working on it.
Yeah, and we talk about the multi roles where some people of respiratory are running CVGs and AVGs, but you play an active role in the delivery room too, and are big leaders in neonatal resuscitation down in the DR. You're the ones that are there, at those crucial moments at delivery. So that's a whole other collaboration that you're working with at the medical team, the OB, and
And I like it when I have deliveries. The other day I had deliveries, and I will admit, I think within a few hours I had 2 or 3 deliveries, and so I missed a lot of my morning. The nurses had to do CPAP care with each other that morning, but I like having deliveries. I feel like some of these babies come up to our unit on CPAP. And at other times for the sicker babies, we get to be a part of the intubation. We don't actually intubate. The respiratory therapists at our hospitals don't actually intubate, but we are a part of like the neonatal team. Maybe we do some surfactant administration, and we bring the babies back up to our NICU in an isolette that has the ventilator attached to it. And once we get there, another respiratory therapist is meeting us up there, and they're ready with the appropriate equipment to transfer the baby over to. So I love having deliveries, though. And when I look at that delivery board and I try to see, okay, this is what I have for today. And you never know when that pager is going to go off.
nope. And it's always, you have a sense of, like, as a nurse that goes down to deliveries, when there's a certain respiratory therapist working, you're like, okay, everything is going to
Yeah.
be okay, because I know they are on, and, we'll be fine.
And we
That's
think the
how
same thing
dependent.
when we see,
I'm
yeah, when
sure.
we see you guys, and we're like, oh, okay, who's on deliveries today?
Respiratory is also without a lot of challenges. And I know one of the challenges that every NICU faces not all, if you're lucky, is unplanned extubations. I know it's something that every unit is tracking, and they want to try to make improvements on their numbers. What are your thoughts on unplanned extubations, and what is your unit doing to prevent them?
Okay, well, I feel like within our unit, actually, we've been doing really well. I can't recall that we've had, especially when you look at how much skin to skin and parent holding we do within our unit. I think we're doing a great job. I think probably, I mean, a lot of times when a baby grabs the tube and pulls, sometimes it's out of our control. But for the most part, I think what I like to do is, first of all, when the bedside RNs have report in the morning, the night shift and the day shift, they do look at that ET tube. They look at the the integrity of the tape, and they measure it. And then I come in after the night shift nurse is gone, and we kind of have a conversation. We also look at the ET tube. So now we've had 2 nurses, a respiratory therapist, we've all looked at it. And if that tube looks like it's not measuring appropriately, or the tape looks questionable, baby's been maybe throwing up or drooly, we make the decision to retape it. Something we've been trying to utilize more in our unit is neobars. And we have kind of a mixed census of there's those who do not like them at all, and other people like me who absolutely love neobars. But not every baby is appropriate to use a neobar on. They have to have enough flesh on their face. And a lot of the babies in the small baby unit are so tiny, and their skin kind of slides back and forth. But I mean, they make them in such a wide range of sizes now that we could probably use them more than what we do, and I try to. So,
and what is your trick on getting the neobars to stay on a preemie's face with humidity? Do you have a trick for that?
Well, the only thing that I have done that's worked, and it doesn't work with every baby, and sometimes I just have to make that judgment call that I'm not going to be able to do my neobar. But after we get it on, first of all, it's super important to measure it appropriately. A lot of people, after it's placed, and if you look at it, it's actually going above the upper lip. So it's actually if you use a neobar correctly, it should be a straight shot right down the back of the airway. It should not be touching the gum, the palate. It should be literally just corner to corner of the mouth. But a lot of times, unfortunately, it's hard to do that if you're not used to putting a neobar on. And after you're done and you look at it, it's actually above the upper lip. So it's probably causing more of it's going to, leave a little bit of a groove in the gum, and it might be rubbing on the palate. So the way that you apply the neobar is probably the first thing. Secondly, is it going to adhere to the cheeks? Because like you said, there's a lot of humidity. And what I do, a lot of times it looks great at first, and then literally 15 minutes later, I look and one of the corners is already lifting.
Yeah.
And so I have been using Tegaderm. And I just take a Tegaderm, and these babies are so little, like you can literally cut it in half like a rectangle, like from end to end. And then I kind of crisscross it on over the pad so that it's actually catching skin, a little bit of skin on the top and the bottom, just to kind of hold that pad down a little stronger. And I have found that for the most part, that seems to work pretty good. And if for some reason it doesn't and it starts to lift, we just go back to the old way.
The tape. Yeah. There's so many devices.
I like it when the nurses if the nurse wants to try it with me, I like that. So
yeah. I know you always have the OG nurses that love their tape and refuse to try the all the devices that are out there. But I really think, like you said, knowing how to put it on correctly is half the battle. And if you can put it on right, it should work.
So you just have to have a conversation with the bedside nurse. You guys got to know that you're both doing the same thing and how it's, because someone's holding the tube and someone's placing the neobar. So if you have that conversation before everything is untaped, that's a good thing.
How everything is secure is so important for prevention of unplanned extubations. And I think that's the thing that we focus on the most is that tube secure? And I said earlier how you guys are magicians in securing the tubing and making sure that everything, isn't pulling when we have our babies all snug up in their isolates. So that's also really important because no one wants to be that nurse that is the one that has an unplanned extubation. Everybody has their quality metrics boards in their unit, and then they see that number pop up, and everybody wants to know who did it, who's nurse, what nurse was it?
I know, who was on?
Yeah, and you don't want to be that nurse. So I love to hear what other units do to prevent unplanned extubations.
And we don't just check it in the morning. We check it throughout the shift. We'll check it several times. We check it before we do skin to skin. We check it again before we put baby back to bed. I have actually retaped a tube while baby has been on the parent.
Oh, wow.
Literally in a recliner. Tube was loose. The nurse was saying, well, I think we need to put him back. The tube looks loose. And I said, actually, it's probably safer just to do it right on. We actually did it right on Dad.
Oh yeah, because trying to move him over.
You should have seen the look I got. And then we actually just rolled baby onto her back, and Dad contained. So she was laying on her back on Dad's chest, and we both of us got down. We were pretty much on our knees doing this tape job, and it was done. And he was able to turn her back over on her belly and finish skin to skin.
Wow.
So, and I felt better because we weren't transferring her back to bed with a loose tube. So.
Yeah, that's true. That's true. God, I've been a NICU nurse for a very long time, and I still get nervous every time I have to retape a tube. Every time.
Mm-hmm.
So it's like one of my most fearful things to do in the NICU is to retape an ET tube. So
I know.
That's why.
And it should be a healthy fear because a lot of these tubes aren't in very deep.
No. And it's not like you said, like the smallest little movement can really make or break tube positioning for these kids. So that's why it's really important that we are constantly checking tube placement.
Right.
And the collaboration, again, we go back to collaboration. That's why we have to have a good relationship with our respiratory therapists on the unit.
Yeah, I know. I mean, I've had nurses call me in and just say, hey, what do you think? And then I look and we decide, oh, it looks good. So it is nice just to get a second set of eyes.
Another challenge that we're facing with non-invasive ventilation that's being used way more frequently, like CPAP, NIPPV, we're seeing a lot of skin breakdown using different interfaces. And a lot of kids, we have that challenge of trying to minimize any kind of leaks that we're finding with these babies with the prongs or the mask or whatever interface that we're using. Do you have any tips or advice to minimize these challenges we face with the kids on non-invasive ventilation?
Yeah, actually, we have a skin expert team. And we have really started watching very closely because we did go through a time where we were noticing that we were getting more breakdown than what we'd ever had before. So we kind of took a step back and tried to see what are we doing, what were we doing before, like what has changed, and what can we do to better the process. And I think myself personally, and there's a lot of respiratory therapists, I feel like we are doing non-invasive on more and more babies that are younger rather than having them intubated. So therefore their skin is so much more fragile than a baby. Like for example, a 24-weeker on CPAP versus a 32-weeker. You're going to really have a lot more breakdown to watch for. So what we started doing in our unit, and it's not easy, and this is where a lot of collaboration comes in, and it takes a lot of extra time and effort, is we, first of all, we try to fit them with prongs if possible, so that we are alternating back and forth between a mask and prongs. Not all the small babies fit into prongs. We have a variety of different sizes, and believe it or not, sometimes the smallest prongs are too close together. The diameter is perfect, but they're too close together. And then you go to the next size, and now the spread is perfect, but the diameter is too big. You know what I mean? So you're getting, like, they won't fit in their nostrils. Yeah, it's like you wish they had the size in between. So we try prongs. So what we do is we do a lot of communicating with each other. Like I'll try prongs and I'll say, okay, the 3520s were too close together. This size she's not going to fit into probably for several days. But we try every couple days. And so then we get a mask to mask order. We have to get an order to go mask to mask. And we put duoderm on the bridge, and then we put a little T on their philtrum and their septum. And we leave the duoderm on for 3 days. So every 3 days, or as needed, we switch out their duoderm on their bridge and the duoderm on their philtrum and septum. And that has prevented, and then we also took another step further. We go in and do CPAP, kind of not full care, but we do 2 full CPAP cares every 6 hours. But then at Q3, we just go in and we go back and forth from mask to prongs. So if a baby's been on a mask and it's coming up on 3 hours, we will, as non-invasively as we can, now we're not going to do a full care time, literally go in there, undo the straps, switch it from mask to prongs, and put it back down. And then 3 hours after that, we do kind of our full care time when they wake up. And we'll do suctioning if needed, wiping, and then we'll switch back to a mask. So they're alternating back and forth so that you're not, the device isn't sitting on the same pressure point for 6 hours. It's being switched back and forth every 3 hours. But again, that's a lot harder than what we thought it was going to be, because it takes a lot of collaboration. It feels like you just get all your babies done and it's time to go in and switch them all.
Yeah. I mean, it's so much better for their lungs, and it has decreased, our BPD rates, but, everything that's positive always has to have a little bit of negative.
But I feel like it's really helped. I think our skin breakdown, we're so much more aware of it. And if we take the duoderm or we see anything that looks weird, we call in our skin experts. Sometimes we take pictures of it. And then there are times when we say, okay, let's not use the duoderm on her bridge. We want to watch this, so we're going to use Mepilex. So then we'll put Mepilex on, which is more of a spongy. And then we'll change the Mepilex out every care time because it tends to hold moisture. But that enables us to peel it off, look at it, and put a new dry one on. So we do kind of have a written policy on how we follow. They wrote a policy for us that we actually follow.
That's great. Mm-hmm. And with the duoderm on like the septum area, you find that doesn't interfere with fit or anything with the prongs, since...
If you cut it right, it doesn't. But I am not a very crafty person. And so when I have a nurse who tells me that she'll cut the duoderm for me, I'm like, I'm so happy. I hate cutting that. I can cut the one on the bridge, but the one on the filter, that little T. Yes. Because if you have that too wide, it goes over the nares.
Exactly, yeah.
So, and again, with moisture, there's times I take their mask off and I see it sliding across their philtrum. And so then I just put a new piece on. But it is, this whole process, it's very beneficial, but it definitely takes a lot more, work with the nurses and the respiratory therapist. But it's worth it.
Yeah, and let's hope, now that there seems to be a movement towards this, and this is going to be our treatment, hopefully those companies out there can start developing and creating things that'll be a little bit more easy to secure and protect skin, and maybe they'll decide to size their prongs a little bit better for these.
I hope so,
micros.
Because we've had a couple of very tiny little babies that have had breakdown, and we have actually alternated between high flow and CPAP just to give them a break from like the nasal or the CPAP interface.
Yeah, it's hard. It's a challenge.
Mm-hmm. Yeah.
What do you want nurses to know how to improve our teamwork and collaboration with respiratory therapy?
I want nurses to recognize that we can be friends, that even though we wear different color scrubs, that we are actually on the same team. So I'm asking for maybe an open mind to having the input of a respiratory therapist at the bedside. And sometimes that might mean a different perspective, but just remember that we're all working toward the same goal. So I love my job. I think a lot of respiratory therapists, probably I can maybe be speaking, I got to speak on behalf of my other RT peeps out there. But I think we all love what we do, and we all want to have better collaboration amongst all the practices in our unit. For those of us who specifically work in the neonatal world, I think just watching the transformation of these tiny little patients over the period of weeks and sometimes even months, and forming relationships and trust with family members, that's something I love. I love working with nurses to help parents understand what is happening with their premature babies while they're in the NICU. I am learning a lot, too, from the bedside nurse. It's not that we know everything. I learn a lot of stuff from the nurses, probably more than anybody else in the unit. I love doing skin to skin and watching parents, their faces for the first time they get to hold their baby. There's a lot of rewards and benefits to a career within the NICU. Um, and then add into the fact that there's a lot of medical advances and a lot of technology that has improved like infant survival rates. And even though working in the NICU at times can be heartbreaking, I think it's really rewarding and it's probably one of the most interesting units to work in. These little humans are the best patients. They are tenacious, they're strong, and they are so resilient. And I think that's just really amazing. And I think a lot of us that work in the NICU can actually say that we've witnessed miracles.
I always say that the NICU is the best kept secret in any hospital. It's the best place to work. What we see and what we do every day is quite amazing.
Yes, it is.
Like I said, I love respiratory. We rely on them so heavily on our unit and all of their knowledge and their expertise. I'm always seeking them out to help me with everything. And, I think you shared amazing tips and ways that we can improve collaboration. And, we're all here for the babies, right? And we're all here to improve outcomes. So you need to utilize all of your resources. And if you're one of those units that are lucky enough to have respiratory therapy by your side 24/7, use them. They have so much to offer. Your efforts do not go unnoticed. I thank you so much for sharing all of your knowledge with us today. So thank you.
Well, thank you for having me.
Make sure you never miss an episode of NANNcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.